Dr. Subramanyam, a family physician from Bangalore, Chamraspet. I've been practicing since 4 decades, and my special interest is diabetes, hypertension, and lifestyle management. Today, I would like to share my views on latest update in hypertension. We are all familiar, hypertension is a major illness causing huge mortality and morbidity among population. As per WHO, nearly 63% of total deaths in India are due to non-communicable disease, of which 27% are attributed to CVD, which affects 45% people in the age group of 40 to 69. Raised blood pressure is among the most important risk factor for CVDs. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of men and more than 53% of women living with hypertension did not get treatment. Medication was used to control blood pressure. Less than 1 in 5 men and 1 in 4 women with hypertension worldwide. This is really sorry state of affairs. These are global figures. Forget about India. In India, the figures will be even worse because of the lack of awareness, economic condition, and unavailability of medical facilities. So it really alarming and frightening condition. So International Society of Hypertension, ISH, has released the ISH 2020 Global Hypertension Practice Guidelines. So let's see how it goes. The AHA by ACC has released a scientific statement in 2021 offering new guidelines for management of stage 1 hypertension among patients with ASCVD risk. Among low-risk adults where no ASCVD or 10-year CVD risk less than 10%, with stage 1 hypertension, where blood pressure ranging systolic 130 to 139, diastolic 80 to 89 millimeters. This is a borderline hypertension or stage 1 hypertension. Management starts with non-pharmacologic therapy, which includes lifestyle management, diet, exercise, habits, stopping smoking, alcohol, weight reduction. Quite often, with these measures, the blood pressure in the stage 1 can be controlled or brought back to normal. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacogenic therapy. Acute respiratory distress syndrome, ARDS, is potentially a fatal condition involving lung damage, and experts often associate it with severe COVID-19. We are all familiar in the last 2 years. So a recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19, including ARDS. It's a new information. So using metoprolol in COVID-related ARDS is beneficial. Lowering systolic blood pressure targets down to 110 to less than 130 millimeters of mercury can substantially reduce CV adverse events in the STEP randomized trial, affirming the sprint findings for the older Chinese population. Among some 8,500 patients ages 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guidelines on the Management of Arterial Hypertension recommended the diagnosis of hypertension should not only be dependent on the office BP measurements, but also on out-of-office measurements such as ABPM or home blood pressure monitoring HBPM, 24 hours, and nighttime BP measurements was associated with greater risk of mortality and composite CV outcome. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 or 10 millimeter increment of blood pressure measurement at night, the risk of mortality increased by 23%, and the risk of cardiovascular events by 36%. It's really frightening. In my experience and all our experience, the nighttime blood pressure monitoring, ABPM, is still not in good, sufficient practice. Only rarely it is practiced. Only now the awareness is improving. It shows very important. The ABPM may be expensive, but asking patient to buy a blood pressure monitor apparatus and record at specified intervals during day and night for observation and understanding goes a long way, which I've been practicing now in the last few years. For the control of blood pressure and cardiovascular events has considerably come down in my observation also. Most patients with hypertension require lifelong medical BP control is a known fact. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of low BP targets, to start antihypertensive therapy with initial dual fixed dose combination, which is ACEI or ARB plus CCB or diuretic as first line, which gives better control of blood pressure because of different modes of action, mechanism of action with lower dose of each one of them. Since early July 2018, products containing valsartan has been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrosodium methylamine, NDMA, which had made a lot of headlines in the recent past, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. So better to avoid these molecules containing NDMA. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy experts favorable CV reduction. So, administering BP medicine in the night has found to be better BP control and better CV deaths. It's so simple, shifting from morning administration in the morning to night administration. We all know circadian rhythm. Quite often, MI happens in the early morning. By administering BP medicine in the night, that can be reduced. So, dear friends, we are going around the same issue. First point is we know how much risk is associated with hypertension, and we know hypertension is poorly recognized, diagnosed well on time because people don't have symptoms, they'll have high blood pressure. Most of them are incidentally picked up. So we should make it a point to check blood pressure of almost everyone who walks into our clinics for whatever reason they come. In the bargain, in my practice, we have picked up in hundreds and thousands of people with hypertension, even sometimes very high blood pressure without no symptoms at all. So thereby we'll be doing great service to the community and proper monitoring, and making people to possess a good certified blood pressure apparatus, keep at home and train them how to record and advise them when to record and ask them to report to us whenever there is deviation, so that nowadays this COVID has taught us new approach in management of patients. Now I have also learned to manage online. See, for checking blood pressure, they need not come to our center clinic. It is really cumbersome. And also we know white coat hypertension. The reading we get in the clinic may not be similar to what reading we get from their home. So we should make the life of hypertensive patients easy by making them to understand the consequences of uncontrolled hypertension and also make them comfortable saying by controlling blood pressure, no need to worry about the complications. We can minimize complications. So this goes a long way. And blood pressure targets has been fixed to be on the lower side. Most patients require lifelong medication. We should make them understand when they record normal blood pressure, it is not called cure, it is called control. They are not supposed to stop medication. We should go on reaffirming them the importance of continuing blood pressure medication. So again, we should avoid using products or BP medicines containing NDMA, carcinogenic. Finally, the importance of administering drugs in the night has to be reaffirmed. We all shift from morning dose to night dose modification. We can reduce CV deaths and morbidities to considerable extent. With this, my dear friends, I hope I'm able to give you some new information about hypertension. Thank you for patient hearing. Thank you very much.